Dr. Tanushree will be introducing about him after this. And apart from that, Murthy has a passion for research. That he has also started a non-profit organization known as IDBR, Institute of Drug Delivery and Biomedical Research in Bangalore, with which even I am associated. So he's got several grants, and then a lot of good research is going on in IDBR, and he has grown leaps and bounds, and he has made all of us proud. And it's indeed truly a privilege and honor, Murthy, to have you with us today. And then I think without wasting much time, I would like Tanushree to introduce him so that Murthy can start off his talk. Thank you.
Thank you, ma'am. And it is a privilege to welcome our esteemed guest and also the alumni of Alameen College of Pharmacy, Dr. S. Narasimha Murthy. Dr. Murthy completed his PhD from Bangalore University under the mentorship of Dr. Shobha Rani Hiramat ma'am. He completed his postdoctoral research at the Roswell Park Cancer Institute, Buffalo, New York. Dr. S. Narasimha Murthy is the Professor of Pharmaceutics and Drug Delivery and Associate Director of the Center for Pharmaceutical Technology at the University of Mississippi School of Pharmacy. Dr. Murthy is also the founder director of philanthropic non-profit research organization Institute for Drug Delivery and Biomedical Research in Bangalore, India. In the US, Dr. Murthy's research programs are funded by the NIH, US FDA, and the pharmaceutical industries. At IDBR Bangalore, Dr. Murthy's team has secured over 8 major research grants since 2013 from BIRAC, BRNS, and the pharmaceutical companies. He has published over 120 research papers and presented over 200 scientific posters in various national and international scientific meetings. He has authored 2 books and 15 book chapters. Dr. Murthy has received several awards, such as the New Investigator Award and the Cumberland Researcher of the Year from the University of Mississippi, Global Indus Technovator Award from MIT, Endowed Chair for Research at the Ohio Northern University, and he was inducted as the Fellow of American Association of Pharmaceutical Scientists in 2017. He was bestowed with Distinguished Scientist Award by American Association of Indian Pharmaceutical Scientists in 2018. This is just the tip of the iceberg. His credentials are endless. I would now request the participants to kindly mute yourself and off your videos during the session. Put in all your queries in the chat box. Sir will answer all your queries once he finishes with his lecture. Without much delay, over to you, sir, for the session. Thank you.
Thank you so much for the introduction. Thank you, Dr. Shobha Madam, for the invitation, and everybody in the organizing committee who has put together this webinar. I'm so honored to be presenting to the organization, which is research intensive, and it's my alma mater as well. So thank you all for inviting me. Can anybody confirm me that my audio is working fine?
Yes, sir. It is fine.
Should I be louder? Am I good?
You are fine, sir. Loud and clear.
Sure. Thank you so much. Okay. So I selected this topic for presentation, nose to brain delivery of drugs, because this is one of the areas of research that I have been pursuing past several years. Of course, topical and transdermal delivery has been the mainstream area of research in my group. But we started working on nose to brain almost like 10 or 15 years ago. We looked into several types of applications using this route. So we do this research mainly here at the University of Mississippi School of Pharmacy, lab. Not much is going on this area at the Institute for Drug Delivery and Biomedical Research. So most of the research that we are focusing on in IDBR are more in biomedical perspective, or from the transdermal dermal perspective. So all the data that I would be presenting today are generated in my lab. A few of the examples from the published literature, just to start the topic. And then I'm going to just present some 3 or 4 case studies that we looked into on the data. So I'm trying to be critical on myself. That's why I call this as myths and facts, not directly showing it like a good success story, because we have to be critical about everything that we do, so that we are able to accomplish a better delivery system, a better pharmacokinetics or target levels and such things. So the picture on the left shows, hope I will, I'll make my laser pointer come up. All right. So the picture on the left shows the theme of the topic that I'm going to talk today. Basically, we are talking about delivery of drugs to the brain via intranasal route. So when I say intranasal route, this is all the nasal tract, basically the respiratory part of the nasal turbinus. And then we have this, if you go up to the roof of the nose, we have this olfactory region. So where you see all the olfactory neurons, ciliated cells located, and they connect to the olfactory bulb. And from the olfactory bulb, the olfactory neuron would end up into the brain and cerebrospinal fluid. I'm going to show more in detail about the anatomy of this region. So this is the overall path. So this path has been known since several centuries probably. So people have been publishing research on the existence of this path from nose to brain in the alternate fields, like aromatherapy. People say if you smell flowers, your memory will increase, and then Ayurveda and other fields. People have been using this route for the 2 purposes, mainly to deliver drugs or to stimulate the brain for different treatment of different ailments. So I'm going to talk about one of the very interesting research papers. Now, why I say interesting is, like, this was a very systematically performed research paper published in Science recently. So the investigators performed a study in which they looked at, this is basically a learning and retrieval type experiment, right? So they made the human subjects learn something at around 8 o'clock in the night, and then they went to bed around 12 o'clock, and then they were offered with a scent, okay, a rose scent, to give them an olfactory stimulus, and eventually in the morning they were asked to retrieve what they learned. So they did different types of experiments in which they offered the scent while they were learning, and they offered the scent while they were in the deep sleep phase of their sleep time, and then they also offered the scent sometime during, which is not during the deep sleep, some other phase of the sleep, and then they also offered them when they were walking while learning. Okay, so different types of experiments were performed, and then the bottom line here is, when they were asked to retrieve the contents that they learned in the previous day. So you see, look at the top right graph. So the vehicle led to a retrieval of about 85%. So what this means is all the subjects they selected were not really dumb. They were quite smart people. Okay. So it's why I'm telling you this is, if the people have, if the subjects had a retrieval rate of, say, 30%, 40%, and if it gets enhanced to some 50, 55%, that kind of a data can be easily generated with a high power, with less number of samples, but less sample size rather. So, but in this case, you see, the people were able to recover or recollect the contents they learned quite a bit, quite well. About 85% recovery is a normal recovery for us. And they, because they were offered the rose scent when they were in the deep sleep mode, they were able to recover almost close to 100%. So this is a significant difference between the vehicle and the people who were offered with the odor during the deep sleep phase. And the bottom graph shows that, when the people were offered with the scent during walking, they could recover almost this, they could recover almost the same amount of content as the people who did in the control group, in the vehicle group. But whereas, the people who were offered the scent during the deep sleep phase were able to recover almost 100%. So what this tells us is, the kids out there who are giving exams, so this is a good a take-home message for you. So have somebody offer. I don't think that's possible. Have somebody offer the rose scent or any pleasant odor when you're in deep sleep phase in the night. Before the exam, you learn a lot of things. You want it to be retrieved during the examination. That may be one of the take-home lesson from this particular study. Or just pour some pleasant scent that you like on the pillow and then sleep. Maybe it might help. Let's try something like this. So the point I'm trying to make is not really to tell you all to do this experiment at home. The point I'm trying to make here is, this particular experiment was performed with a good number of human subjects, and this shows that there exists a path between the olfactory region to the brain. This shows that if you stimulate the olfactory region with a pleasant olfactory stimulus during the deep sleep phase. Okay, so there is some kind of a biochemical memory related reactions going on in the brain, so that might help enhancing the memory. So this is just an example for the existence of the path from the nasal tract to the brain. So as I mentioned, this path is very well known to people since several centuries, I would say, because even in the ancient medicine, Indian medicine, there is mentioned by Charaka, Acharya Charaka in his Acharaka Samhita says, Nasya is the best treatment for Shirorogas. Nasya is intranasal treatment. It is one of the treatments among the Panchakarmas. So he's saying Nasya is the best treatment for Shirorogas. Shirorogas are some of the rogas that are diseases or disorders pertaining to the head. But he's not being specific to CNS. So he meant all the ailments that are related to the sinus cavity, maybe the trigeminal neuralgia, cold, and everything are considered as Shirorogas. But Acharya Vagbhata, who was a disciple of Charaka, not the direct student, he was a disciple because he came around 680, but Charaka existed in 300 BC. So Acharya Vagbhata, in his book, he says nasaha shirasodwaram. So this means nose is the easiest and closest opening to the medicine, to deliver medicines to the cranial cavity. So there is mention about this nose to brain pathway in the Charaka Samhita as well as in Vagbhata's books. There are two books written by Vagbhata, so he mentions about it in one of the books, and that's why this kind of a treatment, nasya, is a type of treatment which is used in Ayurveda for treating several ailments. But what is interesting is the nasya is also used for treating psychosomatic somatical disorders and CNS problems. And there are three different types of formulations that are available for nasya treatment. Nasya is nasal medication, as I mentioned. People use powder, people use oil, and people also use what is called as dhumanyasa. Dhumanyasa is where you are inhaling the fumes. So basically a fumigation process. So I did not find many research papers in which nausea treatment is available for or has been used for treatment of CNS disorders, but I came across one of the studies in which the nausea nasal medication was used in coma patients. Okay, the patients are unconscious, and it's such a great route of delivering drugs to the CNS when the patient is unconscious, and you are still able to make them inhale or maybe administer some kind of a liquid or powder dosage forms into the nasal tract. So they talk about use of trikantu churna. Trikantu churna is nothing but an equal mixture of ginger, black pepper, and long pepper. And then they also gave some kind of a formulation for dhuma, that is fumigation. So fumigation as well as powder via intranasal route seem to have improved the assessment criteria of coma patient. So this is again not a very well controlled study. This is just one of the case studies that I came across. So there is nothing like a control group and a test group, such systematic study performed. This was just a case study that was reported in one of the Ancient Science of Life journal editions. So this is about what has been published so far from ancient medicine, as well as from some of the other areas like alternate therapy areas like aromatherapy and such things. So we also know that the microorganisms, particularly the fungal infection of the brain, which is called as cryptococcosis or cryptococcus meningitis. So we know that so the cryptococcus meningitis of the brain leads to edema of the brain, and get severe if it is untreated. It can even prove to be fatal. So the cryptococcus is known to travel from the intranasal route to the brain via the olfactory pathway. So one of the research papers that was published by Stanford and other organizations across the globe found that this was in rats, in the rat model. So they used Cryptococcus neoformans and Cryptococcus gattii. So these two were the organisms used for testing. They inoculated the nasal tract. They administered the organism by several routes, but I'm just showing you only the results of the in nasal route. So when they administered these organisms in the nasal route, within 3 hours, you see that within 3 hours, they found the cultures in the fungal organism in the olfactory bulb. So this is the olfactory bulb and the brain. Significant amounts were present. So you look at 24 hours. Okay, so it's not really highly different from what we see in 3 hours. So what this means is these microorganisms know the path very well. So they are able to travel from the olfactory region to the brain within a short span of time. Within 3 hours, it is able to reach to the brain. So the microorganisms know the road pretty well, and they infect the brain within no time, and this meningitis is a serious disorder. So another very scary publication that I saw, which is again a Stanford group as well as other groups published, is again about one of the forms of microbes, amoeba. So the brain-eating amoeba. So this N. fowleri. Um, so N. fowleri is a type of amoeba which lives in fresh water and warm water. So when people come in contact, or when they're taking bath in the river, so this organism will enter into the sinal cavity. So the sinus cavity. So the from the sinus cavity, in the sinus cavity, it grows and it forms a tropocyte. The tropocyte form is the one that travels along the olfactory path into the brain. And then once it goes into the brain, it starts feeding on the brain tissue, and it grows up. It blossoms into a full-fledged flagellate, and causes edema and a lot of other complications. So even the organisms, microorganisms of the size of amoeba, are able to travel via this path. So So this is nature, right? So nature has no boundaries. They can overcome the limitations of physiology, and they're able to do what they're able to do. But are we able to deliver drugs via this pathway is our question, right? So let us take a systematic approach towards analyzing whether we can deliver the drugs through this route into the brain. People have published a lot of papers, and we have published a lot of papers also. But we always kind of revisit this and being very critical about um, our own data and the results that we keep getting day to day in our laboratory. So this is the anatomy of the olfactory region. So basically, these are the ciliated olfactory cells, and there are some of the basal cells. So this is the part that is exposed in the nasal cavity, and there is a layer of mucus present on this. So this is the part that is exposed in the mucosa. So, and then these cells will all these olfactory cells will connect into the olfactory bulb, and there is a junction present in the olfactory bulb, and then beyond this, again, these neurons will continue in the form of a bundle and reach the brain and the cerebrospinal fluid. So that is the pathway. So there is still a lot of debate going on. How would molecules that would be taken up by the neurons end up jumping from the first bundle of neurons to the first bundle of olfactory neurons to the second the bundle of neurons in the olfactory region? So how is this transit possible? Because the smell, when you perceive, okay, so the electrical stimulus will pass through the cells, and there is exchange of neurotransmitters here, which will be able to take the impulse to the brain. But in this case, we are talking about the molecules propagating from this region, the olfactory region, via the olfactory bulb through this junction where there is a gap, basically, right? The neurotransmitters are the only means of connecting these two sets of neurons, and then the molecule will be traversing towards the brain. So let's take a much closer look at the region here again. So these are the olfactory cells and the basal cells. Suppose if the drug molecule is able to pass through the extracellular region, then it would end up into the CSF, the cerebrospinal fluid. If it is able to go into the neuron, either inside the neuron or through the perineural fluid, or inside the perineural fluid, if it's able to propagate up in the olfactory region, it is going to reach the brain. Most of it is going to reach the brain. So, so there is opportunity to deliver drugs to the CSF as well as to the CNS, so to the brain. So let us look at what all possible ways we can deliver the drugs from the olfactory region into the brain. So when you deliver the drug into the nasal cavity, there's a lot of drug that gets drained out, and any drug that gets absorbed from the nasal tract into the blood would reach the systemic circulation and undergoes distribution or undergoes metabolism, or whatever the natural process of dealing with the drug by the body would happen. But the nasal cavity has this region, olfactory region, so through which we are supposed to deliver the drug to the brain. So let's understand the limitation and opportunities, right? So before we explore any drug delivery system, this is a very important thing. So we need to explore the limitations of this route of administration. So this olfactory region, if you take a look at the anatomy, you will see that the region, the overall area of the olfactory mucosa is about 1 square centimeter to 2 square centimeters in human beings. Of course, in rats, the area is much larger, or the ratio between the olfactory region to the other part of the nasal mucosa is much higher in case of to rodents as compared to humans. Okay, so there is a huge gap in terms of the area available for absorption of drug to the size of the brain and several things. So we have to consider those limitations. And when the drug reaches the olfactory region, would it be able to passively get absorbed across the olfactory mucosa into the brain tissue? That's a bigger question, right? So, and then is there, so as formulation scientists, we are interested in always enhancing the delivery. So in this case, we are questioning whether we can use something like permeation enhancers. So I'm using the word barrier modulating agents because permeation enhancers would choose, I mean, would suit better to just the buccal mucosa or the skin, where the chemicals would act on the lipid membranes. But in this case, the scope for using chemical permeation enhancers which would act on the lipid membranes is very limited. So all that we can do is mainly alter the dynamics of the tight junctions. So the tight junctions open and close, and you will be able to enhance the delivery across the mucosa through this tight junction area. So what are these tight junctions? If these are the only pathways existing for us to modulate, then what are these tight junctions? These tight junctions are mainly the components that would hold the cells together. They are present in the epithelial cells as well as in the endothelial layer, epithelial layers as well as endothelial layer. Just the architecture of it would be a bit different. So we have tight junctions, and then we have the adherence junctions. All these are components of the anatomical structures that hold the cells together. So these tight junctions, so let's take a look at this picture here. These tight junctions are inherently conductive to ions. Okay, so they're inherently conductive to ions because, you know, to manage some of the biochemical physiological processes and several other things that are going on in the epithelial region, like you know, transporting the stimulus and such things, you would need the ion conduction to go on, right? So the question now we have is, can we deliver macromolecules? So by the way, this is a paper that is published in Nature Reviews. This is a very, very nice article. They completely discuss the entire structure and the proteins that are associated, the dynamics of tight junctions in different barriers in the body. So the question now we have is, can we deliver the macromolecules? It is known that even through the tight junctions, there's some amount of macromolecules can pass through. So it is called as leakage pathway. Okay, so through this leakage pathway, there's some amount of macromolecules are able to traverse across the membrane. But if you want to deliver larger macromolecules, then you probably may have to open up the tight junctions. So what is the way we can open up the tight junction? These tight junctions are very sensitive to the microenvironment that we subject to, that we expose the membrane to. Okay, we all know that the tight junctions can be opened using something like you know, ions or some compounds which are like positively charged, which would disturb the calcium balance intracellularly and extracellularly. There are several approaches reported in the literature to show how the tight junctions can be opened and can be exploited for the delivery of drugs. So we hypothesize that, you know, if the ions can pass through the ionic conductance, and if the macromolecules can pass through the leakage pathway, if we modulate the tight junctions and open the tight junctions, we probably may be able to you know, drive in more and more ions, and that might make the membrane more conductive. So let us study the dynamics of tight junctions by the way of looking at the electrical resistivity of this membrane, the olfactory membrane, using an in vitro tool. So we have this Franz diffusion cells. All of you recognize this, and we have an electrical resistance measuring setup at the background. We use alternate current, and we have a setting where we drive in a very small amount of current. Okay, the current is so less that it would not affect the membrane permeability. So if the current increases, then probably it would have its own impact on the membrane permeability. So or membrane resistance rather. So if you look at the picture and the graph here, this is measuring the relative resistance or the percent relative resistance. You see that the membrane resistance in the control did not change over a period of 8 hours. But when we subject when we expose the membrane to something like a chitosan, a polymer, the positively controlled chitosan polymer, you all have worked on chitosan quite a bit. So chitosan is a very biocompatible polymer, and that we use it for different delivery systems, preparing different delivery systems. It is FDA approved as well. So we see that right after exposure, within a span of 30 minutes, we see that the resistance of the electrical resistance of the membrane drops down. And then as soon as we remove the chitosan and wash off the donor surface, eventually and fill the buffer in the their donor compartment, we see that the electrical resistivity would come back. So what this means is that tight junctions are dynamic structures. You can open them transiently by exposing it to cationic polymers or any other approaches that are reported in the literature, and it is possible to bring these tight junctions back to function. I mean, to back the you can make them close up once again, after you take away the stimulus that is leading to opening up the tight junctions. So this is a very nice phenomenon. This is a reversible phenomenon, a safe phenomenon for us to look into for delivering the drugs. So we wanted to see if macromolecules can be delivered. We just took fixie-dextran 40 kilodalton because our objective, or eventually we wanted to deliver some neurotropins into the brain. So that's why initially we took about a 40 kilodalton molecular weight fluorescein dextran. The reason being, the neurotropins that we looked at are all around 30 to 40 kilodalton in size. I know that the 40 kilodalton in carbohydrate cannot be equivalent to 30 or 40 kilodalton in peptides. Peptides are more like a three-dimensional globular structures, and these carbohydrates are more like a linear structures. But still, at least we can study. We can run some preliminary experiments and get a feel for to what extent we will be able to deliver these macromolecules across the mucous membrane. So what you see in the blank bar is the control. So when we use the chitosan, we were able to enhance the delivery, and there was a small increase from 0.1% chitosan to 0.25% chitosan in low viscosity and medium viscosity. By the way, we thought we can change the charge density of the polymer by taking different grades of chitosan. Looks like it did not happen. In all the cases, we found that 0.1 to 0.25 we saw some enhancement, but eventually as you increase the concentration, the enhancement remained the same. So the bottom line here is, if you use 0.1 to 0.5% chitosan, you probably would be able to enhance the delivery of macromolecules by the way of opening the tight junctions. So we wanted to deliver the neurotropic factors. So the neurotropic factors that we considered to deliver were nerve growth factor and brain-derived neurotropic factor. The nerve growth factor has several applications. You know that the nerve growth factor is neurogenerative. It is useful in the treatments of neurodegenerative disorders. There are several other complications associated with nerve growth factor. That's not of interest in this particular area. We wanted to develop nerve growth factor mainly as a treatment for neurodegenerative disorders, and to regenerate the neurons that have degenerated in the brain. And the brain-derived neurotropic factor is another very interesting neurotropic factor. This also can regenerate the neurons in the brain, and also there is a great association of brain-derived neurotropic factor, what we call as BDNF, with the depression. Okay, so depression is known to chronic depression is known to lead to neurodegeneration. So there is a lot of literature out there that shows and, the relationship between depression and the neurodegeneration. So in depressed patients, chronic depression patients, you see that the BDNF, the endogenous BDNF levels are depleted in the brain. So in such patients, even for the treatment of depression, as well as for prevention of neurodegeneration or for rejuvenation of neurons in the brain, brain-derived neurotrophic factors becomes one of the potential candidate. So we try to deliver these two molecules, again, nerve growth factor and BDNF are water soluble. NGF is about 30 kilodalton, BDNF is about 40 kilodaltons. I think NGF undergoes association to form dimers and trimers. And when we looked at the amount of drug that was delivered across the olfactory mucosa, the bovine olfactory mucosa in vitro in 2 hours, we found the control was very less. And as we found in case of fitsidextran, we found an enhanced delivery from 0.1% to 0.425%, and same happened in case of BDNF as well. But take a look at the levels that we were able to get into the receiver fluid. So we looked at what levels could we deliver across the membrane into the receiver within 2 hours, because practically speaking, in intranasal administration, when you're trying to deliver to the brain, when you administer the formulation stays in the applied region for only about 2 to 3 hours because of all this respiratory mechanisms that are going on. So we are able to enhance the delivery significantly, but the levels that we really reached are not really great. So this is about 4 to 5 nanograms per centimeter square, and this is about 200 to 300 nanograms of BDNF in the in the in vitro model. So we thought, okay, let's go ahead and look at the pharmacokinetics in the brain. Are we really able to deliver these neurotropic factors into the brain? So then we thought, okay, let's take up the animal model. So we just took a rodent model. As I mentioned, rodent model has a larger olfactory region as compared to human beings. When I say larger, it's in terms of proportionality. Okay, so so all we did was very simple setup. So there are so many other devices available these days that would help delivering the drugs and formulations directly to the olfactory region, but we just use a microsyringe and a soft polymer capillary and administered the solution to the olfactory region, and we allowed it to stand for 2 hours, and then we performed what is called as brain microdialysis. So the brain microdialysis uses, in this picture, you see that there is a probe going into the brain. So this probe is a symmetric probe. The probe that we use, if you worked on skin and skin microdialysis, the probe that we use in case of dermal microdialysis is called linear probe, okay, where there is an inlet and outlet along the axis. But in this case, it is not so. I will show you the picture of how this probe works. And then after all the studies, we made sure our objective here was to deliver, was to sample the nerve growth factor and the BDNF from the hippocampal region. So we kind of made sure that our probe went right into the hippocampal region. So what region you see here in the section, the brain section, is the hippocampal region, and this crack here, it shows the path through which we implanted the probe, and the rats are alive when you're doing this experiment, and you're able to look at the real-time change in the concentration of drug that is delivered intranasally. So these are the advantages of using microdialysis for looking at the pharmacokinetics of drug in the brain. So the way this works is, like, this is the symmetric probe, and this is the probe that goes into the brain. So you are perfusing the fluid, the buffer that you would want to use for sampling the drug, and it goes into the inner compartment, then the buffer would come out, and all the contents in the brain would be coming into the perfusion fluid because of the concentration gradient, and this perfusion fluid will be collected at the other end. So the membrane that is covering the outside of the probe is a semi-permeable membrane. So there is diffusion along the concentration gradient for the drug to travel along with the perfusion fluid and get collected. Okay, so there's only some amount of drug that is present in the brain would be recovered. So you should determine the recovery. There's a lot of validation to be done. And the probes cannot be used repeatedly. You have to make sure, if you're using repeatedly, you have to make sure that the probes are giving you the same extent of recovery, in a reproducible way. Then only you will be able to get a very reliable data, and data with a lesser errors. So what we found here in the graph is, one is the nerve growth factor and the other is the brain derived neurotrophic factor, the pharmacokinetics of drugs in the brain. So these are neurotrophic factors, and I should not be using the word drug, but we're so kind of used to use the term drug. I hope you get it. So these are neurotrophic factors, exogenous neurotrophic factors that we are delivering into the brain, and these are the baseline adjusted levels. So when we did the intranasal administration of NGF, we were able to see some amount of drug going in. Even in case of BDNF, we see that without the enhancer, there was some amount of drug going, some amount of protein getting into the brain. But with chirisan, by opening the tight junctions, we were able to deliver quite a bit of neurotropins into the brain. So this was one of the approaches. And again, look at the levels. We are talking about nanograms per liter. So it's not like very high levels, but fortunately, excuse me. Fortunately, these molecules are quite effective at very low levels, like picomolar levels. They are effective on the receptors. So you don't have to deliver, microgram and milligram levels of drug. Even in picomolar levels, they are pretty effective. So that's why we were quite happy with the results. But at the same time, we thought it may not be just one approach that would help to treat this kind of disorders. We may have to take multiple approaches to treat neurodegenerative disorders. So besides delivering the exogenous nerve growth factor and brain derived neurotrophic factors, we were looking for some way of enhancing the expression. The brain itself would express the endogenous BDNF and NGF levels would be a great approach. And then we came across one of the manuscripts in which people have looked at several compounds in the cell lines. They screened several compounds that can enhance the BDNF levels and the NGF levels in the brain. So we thought, why not we try those agents? And one of the agents that we picked was carnosic acid. So you all know what carnosic acid is. It's a very good antioxidant. It has several applications. It is used in cosmetic products. It is used in several other formulations also. Particularly the cosmetic products. And the carnosic acid is known to enhance the expression of BDNF and neurotrophic factors. So we delivered the carnosic acid intranasally. So remember, carnosic acid is not a highly soluble compound. We had to solubilize it using cyclodextrin or other solubilizing agents. And then these are the in vivo data. So what we did was we divided the rats into 5 groups, and we administered one with just the vehicle and one without the chirisan, carnosic acid, and chirisan, no chirisan, and then different amounts of carnosic acid with chirisan were administered intranasally. And there was one group, a positive control group, where we had administered the higher dose subcutaneously. Because carnosic acid is known to permeate across the brain because of its lipophilicity, across the blood-brain barrier because of its lipophilicity. So when we looked at the brain levels of NGF and the BDNF. So this is the nerve growth factor and the brain-derived neurotrophic factors expressed endogenously. Okay, so this was again a prolonged administration protocol, not like you administer before 2 hours before you sample the content from the brain. So we administered it over a long period of time, and then we found we implanted the microdialysis probe to sample the endogenous nerve growth factor and the BDNF. So the microdialysis came into existence. It was initially came into research practice mainly for this purpose, for sampling the neurotransmitters and all this neuropeptides and such things as a diagnosis. Okay, people have published even human subject data using this technique, but they're like those are the people, the subjects were like who underwent the brain surgery. They implanted the probe while they were doing the surgery, and eventually they were able to sample the neurotransmitters and neuropeptides. So this is a very useful tool. So when we looked at the levels in the brain, we found that in group 3, in the intranasal route, there was quite a bit of carnosic acid present. In subcutaneous route, there was a significant difference compared to the vehicle in both the cases, but not really as high as what we saw in intranasal. This is understandable because carnosic acid, when we administer subcutaneously, gets distributed all over the body, and very little will be able to get into the brain. So that's the most likely reason why we were not able to see as higher levels of endogenously expressed neuropeptides as we saw in case of intranasal route. So probably we should have increased the dose by tenfold or maybe 2 orders of magnitude to get enough into the brain. For subcutaneous route, I'm saying. So the question now here is, why didn't we do a microdialysis prior to sampling the neuropeptides? The carnosic acid being a lipophilic molecule, it's very hard to sample into the aqueous buffers in that we use as perfusion fluid in microdialysis. So it's so this is one of the limitations of microdialysis. If the drug molecule is not really soluble enough in the perfusion fluid, then you would not be able to sample, or the recovery would be very poor. Even in case of macromolecules, we observed the recovery was very less, at 3 to 4% or 5%. So we have to have a sensitive analytical method to analyze the neuropeptides that are recovered using microdialysis protocol. So going further ahead, we also wanted to do a pharmacodynamic studies because we know that the BDNF is associated with depression. I told you. So we performed a forced swim test in rats. So the rats were subjected to immobilization stress. The pharmacology people out there can understand this better. When the rats were constantly subjected to immobilization stress for over a period of time, I think it's for a week or so, the BDNF levels in the brain are going to deplete. So this is a standard animal model that is already reported in the literature. So look at the group 1, the vehicle control. This is the immobility time. So immobility, higher the immobility time, more depressed the rat is. So group 1, there was no, I mean, group 1 serves as the control for us, so the immobility time for the rats was about 200 seconds. And then just the CA administered intranasally did not help. Only when we use Chedsan with the CA is the carnosic acid. Okay, so it kind of significantly reduced the immobility time by about 50%. But we did not see that kind of a reduction in the immobility time in when we administered the carnosic acid subcutaneously. Again, I blame it on the dose that we delivered. Possibly, if you can deliver a lot of carnosic acid, higher levels of carnosic acid, you probably may see some effect in the subcutaneous route also. Group 5 was a normal unstressed rat. So we are comparing the depressed rats with the rats that were normal. So if you see, there was no significant difference between the carnosic acid group and the normal rat in terms of immobility time. So this shows us that we were able to enhance the expression of endogenous BDNF in the brain over a long period of time when you administer the carnosic acid. And when you do this kind of intranasal route of delivery, we always think about delivering different types of formulations, right? So there are even in the ancient medicine, I mentioned that there is powder and there's liquid and different type of formulation. The formulation scientists have reported the use of nanoparticles and micelles, liposomes, solid lipid nanoparticles, you name it. Every type of drug delivery system has gone into the new nose. Okay, so think about it. I told you the tight junctions are dynamic structures even when they are not open. They offer some leakage pathway through which the macromolecules can penetrate. The size is, when they're not open, the size is about 5 nanometer to 6 nanometers. Okay, the size of the tight junction pathway or the leakage pathway. So that's what if we are trying to exploit for the delivery of whatever drug delivery systems that we are developing. Okay, even when you use something like charisan and open up the tight junctions, okay, just think about it, like how much can we open up? Maybe an order of magnitude. That's what the literature says, about an order of magnitude. Okay, so an order of magnitude would be about 50 to 60 nanometer, right? So that's the maximum size of the pore. Okay, so if you prepare 200, 300, 500 nanometer nanoparticles and liposomes and such things and deliver through the intranasal tract, I don't think those vesicles or the particles would be able to penetrate across the mucous membrane intact. They may be leading to some level of enhancement in the drug delivery because of some other mechanism. Okay, this is what I've been talking about even in the skin area. Okay, people talk about delivering nanoparticles and microparticles and several things into the skin and across the skin as well. But I strongly believe that the particles would not be able to penetrate through the skin intact. It may be enhancing. We have seen some level of enhancement in drug delivery when we used nanoparticles in the skin area. But I strongly believe that it is mainly because of some kind of a thermodynamical mechanism associated with it, rather than the particles itself penetrating into the skin. So that's just my opinion and my out of my experience. So think about all these things, the size of the pathway available before you design your drug delivery system. So if it's of less than 50 nanometers, then probably there is scope for delivering the intact vesicular or particulate drug delivery systems as well. And olfactory region is one such region where the cilia would not have that clearance mechanism. So suppose if you administer something into the nasal turbinus, the other part of the mucosa, the respiratory part of the mucosa, the formulation gets cleared, right? Get drained. Because of the ciliary clearance. But that mechanism does not exist in the olfactory region. So that's an advantage. So you can deliver something like an in situ gel forming formulation, or anything, even the particulate drug delivery system into that olfactory region or on the surface of the olfactory region. It would stay there for quite some time unless it is cleared due to nasal drainage or some other physical mechanism. But not by the ciliary clearance. So that's one great advantage. But at the same time, the formulation that we develop should be quite safe. So we looked at uh, how safe our formulations are, the chitosan based formulations are. So this is on the left hand side, the left panel shows the histology of olfactory mucosa. So this is the control. Okay, but this is the carnosic acid just present in cyclodextrin and buffer, and this is with the chitosan. So we also looked at if our formulations has any impact on the hippocampus region and the other part of the brain. So in the sections, there was no evidence that there is any kind of bad things going on in the dentate gyrus or in the hippocampus region. But in case of mucosa, if you closely observe the top layer here, okay, the top layer got swollen. Okay, so just by being, coming in contact with the captisol, the sulfobutyl ether cyclodextrin, and carnosic acid and buffer, so there is a significant increase in the thickness of the top layer. So this layer is quite sensitive. Okay, so you cannot use even mildly aggressive solvent systems because that is going to lead to irritation of the mucous membrane, and sometimes it might also affect the olfactory mechanism as well. So you have to be very choosy about the solvent, other excipients that you choose to use for developing a drug delivery system to apply to the olfactory region. So just a buffer, just the captisol, just sulfobutyl ether groups, can lead to this kind of inflammation. So this is one of the concerns, but we observed that this kind of was reversible. Eventually the layer came back to normal. So that's why we were not greatly concerned, but definitely this is one of the factors that one would need to consider when they're developing the formulations. So moving ahead with the next application, we did some work on ziconotide. So ziconotide is a conotoxin. It is a 3 kilodalton peptide. It is currently approved by US FDA. It is one of the two medications approved for pain management, chronic pain management via intrathecal infusion route. Okay, so this is approved only by intrathecal infusion route. You cannot administer ziconotide orally or via any other route, even injections and such things. First of all, the peptide does not get distributed into the cerebrospinal fluid. Okay, this is supposed to go into the cerebrospinal fluid. And any other routes will not be able to distribute the drug in therapeutically effective levels into the CSF. So that's why the pumps are used to infuse, the infusion pumps are used to infuse the drug continuously into the cerebrospinal fluid as a means of chronic pain management. And in some devices, the pump goes into the peritoneal cavity, and some devices, the pump stays outside. But the pumps have several complications. So in case if the flow rate changes, if there's any reason for malfunctioning of the device, it could lead to serious CNS side effects and other side effects as well. So there are several complications associated with the mechanics of the pump, and also with the rate of delivery and such things. If there is any alteration, could lead to even significant toxicities. So and the ziconotide is required in very smaller levels. So that's why we dare to look into the delivery of ziconotide from nose to CSF. Basically, our target site of delivery is the cerebrospinal fluid. So let's take a look at what happened when we delivered intranasally and intravenously. So we delivered it by intravenously. We saw some levels of drug getting distributed into the CSF, and intranasally we almost saw the same levels of drug getting distributed in the CSF. And interestingly, we saw the peak levels earlier in case of intranasal delivery as compared to intravenous. So there is there's potential for rapid delivery of drug into the cerebrospinal fluid. Indeed, I would say it's relatively much easier to deliver into the CSF as compared to the brain, because brain, the pathway is pretty limited. It has to, the molecule has to go into the neuron or through the perineural fluid to get into the brain. But in this case, the drug that would just go via the paracellular route and reaches the extracellular fluid would eventually, not all of it, at least a good fraction of it, would be able to eventually end up into the cerebrospinal fluid. Cerebrospinal fluid is also considered an extracellular fluid. So delivery was quite a bit. And then this is again a 3 kilodalton peptide. This is about an order of magnitude smaller compared to the neuropeptides that we delivered earlier. And then again, we used intranasal. We did several different types of formulations. I'm not showing you different types of formulations here because my objective here was to critically assess this route of delivery and the opportunities and limitations associated with this delivery. So intranasal chitosan, again, as I mentioned, the tight junctions open up and you are able to get about 5 to 6 fold more delivery by intranasal route. Okay, and again, you please take note of it that this can be a route for rapid delivery of drug into CSF, and the patient is suffering with chronic pain, and it's possible to get a control over the pain by intranasal administration. And the beauty of this route is frequent administration in such situations is possible. You also observe that the drug is getting eliminated quite rapidly. If you follow this red graph, the red curve, the drug is getting eliminated also. It is rapidly delivered and it is getting eliminated rapidly from the CSF. This is not because the drug is prone for metabolism in the CSF. This is mainly because of the high turnover, the fluid turnover in the cerebrospinal fluid cavity. Okay, so in the subarachnoid space, you see that the fluid, it's not like a standstill fluid, right? The cerebrospinal fluid is continuously flowing. It's like a river, basically. Okay, so that's the reason you see the drug being cleared away quite rapidly. Okay, so in such a case, imagine how difficult it would be to pump the drug at the rate that would compensate this level of clearance, right? So that's the reason why FDA approved only the infusion, not just the injections. Okay, so frequent injections into the CSF region is not preferred. Okay, intraspinal injections or intrathecal injections are not advisable. Frequent injections are not advisable at all. I think, I recall right, you can only give one intrathecal injection. You're allowed to give only one intrathecal injection in 2 weeks or so. Okay, so but in this case, to get enough levels in the CSF, you need to administer more frequently. So the frequent administration would be possible only if you deliver it via intranasal route. So this was one of the applications that we tried, and this was funded by NIH, and this is very interesting work that is still going on. We are exploring different formulations and such things. We're also exploring the development of a control release intrathecal administration right now, to just administer one time, and it takes care of the drug levels in the CSF over a long period of time. The problem with this ziconotide is it's a very effective pain management drug, like as good as morphine or better than morphine, and it has other advantage also, that the ziconotide does not lead to tolerance. Like you might have heard about opioid tolerance. Okay, so that is not seen in case of ziconotide. But the only problem with ziconotide is that it causes severe CNS side effects. So that is the limitation that we are seeing, when we try to develop a control release intrathecal dosage form, because in case if there is any burst release for some reason, if the drug delivery system fails, then the patient would end up getting huge levels of ziconotide in the CSF and
11.5
would lead to severe side effects.
इसका automatic 14 है.
So the next application is delivery of vigabatrin.
इसका next model automatic.
Please mute somebody is speaking in the background. I request them to every participant to mute the microphone. Kindly mute the microphone.
How am I doing with the time, madam? Am I okay? I just have another.
I'm sorry for the disturbance.
Take your time, Murthy. Yeah.
Kindly mute yourself. Please don't cause any disturbance for sir. Such an interesting topic is going on. Thank you, sir, and sorry. You can continue, sir.
No problem. So vigabatrin is one such molecule which is used for treatment of refractory epilepsy in infants. So this is a very serious problem. Okay, about 30 to 40% of the epileptic infants are refractory to treatment. So you understand the word refractory. So that means they are not responding to any of the anti-epileptic drugs. So we're talking about infants, right? So it's a pretty serious disorder, and the epilepsy wouldn't come to control at all. The patients are having, it's really traumatic to see these patients having convulsions over long periods of time. So one of the drugs that is approved for such refractory epilepsy treatment is vigabatrin. It is available as Sabril, I think, in the United States, and it's available even in India as well. So the vigabatrin that is available in the market in the form of tablets are solutions, as you see in the picture. The child is being fed with the solution of vigabatrin. The dose is huge, one thing. And the second thing is vigabatrin is a racemic mixture. The available dosage forms have the racemic mixture of vigabatrin. So the out of the two racemic forms, the S form is supposed to be highly potent. So there's if you go for separation of S form, the R form, then the cost of medication increases. So that's why people are administering, I think, the racemic mixture. And one major problem is that vigabatrin has been approved by FDA with a black box warning. So what is this black box warning? The vigabatrin can localize a lot in the retinal tissue. Okay, so the vigabatrin generally, when it gets distributed, it localizes, it retains in the retinal region in quite high concentrations, and this eventually leads to retinal degeneration and loss of vision in the children. Okay, so that's the black box warning that comes with vigabatrin. So the children who are undergoing vigabatrin treatment, people know that, so there's it's a risk versus benefit basically, right? So they know that this kid is going to eventually lose the sight. Okay, so that's serious it is. Okay, so the administration of vigabatrin is the only way you can control the convulsions, but if you use vigabatrin, you are going to affect the vision of the child as it grows. So we thought, why not we take the S form of vigabatrin and deliver it intranasally via olfactory route into the brain. So the way the vigabatrin works is, the GABA in the neurons would get converted into succinic semialdehyde via the enzymatic conversion mechanism called GABA aminotransferase. So the vigabatrin would block this enzyme. So when vigabatrin blocks this enzyme, the GABA levels go up in the brain, and the increase in the GABA levels is associated with anti-epileptic activity. So this is a picture that I took from the Nature Review, Drug Discovery. So this is what is happening in the brain, and this is what is intended to happen also when you deliver vigabatrin. But as I mentioned, as vigabatrin gets distributed in other parts of the body as well, so mainly we are concerned about the retina, right? So what happens in the retina? Vigabatrin leads to increase in the GABA levels, like the way it does in the brain, even in the retina. So this increase in the GABA levels leads to two different types of negative impactful effects. One is the susceptibility of the photoreceptors to light increases, that eventually leads to retinal degeneration. Even more serious is the drop in the taurine levels, in intracellular levels of taurine. Okay, taurine is a very, very, very important endogenous ingredient. The taurine is present in all your cool drinks and everything. It is a osmoregulatory ingredient. It is also an antioxidant. It takes part in several biochemical pathways and such things. So the taurine level decreases, and the decrease in taurine level has several untoward effects, like the ROS would increase, and several other kind of bad effects would go on intracellularly. The pharmacologists may know this better. So this leads to apoptosis of photoreceptors, leading to retinal degeneration. So with all these things in mind, we thought, okay, well, let's try to deliver vigabatrin through the intranasal tract via olfactory pathway to the brain. So that way we would be able to target the drug only to the brain. That is the target site. That is the site of delivery as well as the site of action. We don't want the drug to go into the retina or to other organs. So if you deliver via systemic routes, any of the systemic routes, oral or parenteral or anything, it would eventually end up in the retina. So we tried this. This was a very exploratory project, because the dose is high, and there are lots of complications associated with, because and even when you deliver intranasally in the form of solution, as I mentioned, not all of the solution will stay in the olfactory region. It would just drain onto the mucus that is associated with the respiratory tract, right? And there's possible systemic absorption of drug, right? So it's hard to overcome this entirely, so that's why we thought, okay, well, let's try some kind of a in situ gel type of formulation. So we prepared a multi-block copolymer based polymer, and this has the property of in situ gelling in the olfactory region, triggered by pH, triggered by ions, triggered by temperature, and several things. So this is a polymer that was synthesized by one of my polymer chemist colleague in the department. So we took up two routes of delivery, intraperitoneal and intranasal, just for the sake of comparison. And the studies were of two phase. One was acute study and the other was chronic study. In the acute study, we just delivered drug one time and looked at the levels in the retina, brain, and plasma. And then in the chronic study, we administered the drug for 28 days. And then looked at the levels of vigabatrin in the blood, retina, and the brain. So we also looked at the GABA levels and the taurine levels as biomarkers, right? So if the vigabatrin is delivered to the target tissue, then there would be an increase in the GABA level in the retina as well as in the brain, and the depletion in the taurine level. So this would be kind of a indicator for us, or the markers for us, to make sure that the vigabatrin has been delivered to the site. So let's look at what happened when we performed an acute study. In the acute study, as I mentioned, it is just a single dose 5-rat study. And in case of intraperitoneal administration, you see that the plasma levels were quite significant, vigabatrin, and we saw quite a bit in the brain. So this is the amount of drug that is present in the retina, microgram per gram. Okay, so there is a lot of drug getting accumulated in the retinal region for some reason. Okay, so this is the main cause for the degeneration of neurons in the retinal region, or the retinal neuron degeneration rather. So intranasal route, because it is a much lesser dose, if you see, and because it was administered intranasally using the gel type polymer, in situ gel type polymer, we did not see anything in the plasma. Okay, and then we saw some in the brain. So this is what we wanted. So this is the target site of delivery. So we were able to deliver significant amounts into the brain. We did not see anything in the retina. Okay, so are we completely successful? We can't say that, because we are limited by the sensitivity of the analytical method. Also, in this case, there may be some leakage into the other regions of the nasal tract, and there may be some potential systemic absorption. There may be some in the retina that we were not able to really detect, but at least it is significantly lesser compared to the intraperitoneal level. And then we also demonstrated that the in situ gel is a viable way, or viable approach for us to take, and mild enough also. At the same time, the polymer did not really cause any kind of inflammation of the tissue. So, and then when the chronic study is, a real picture comes out in the chronic study, right? So we see that again in the intraperitoneal, the scenario did not change. If you take a look at the levels were much smaller in the chronic study. It looks like in the acute study, once the first administration is done, there is a surge in the levels, and then eventually it kind of attains a steady state and stabilizes at some levels, which is like 4 or 5 times lesser than what we see in the acute study. But look at our intranasal delivery. So we saw some in the plasma because this is a 28-day study. Okay, so when we administer intranasally to the olfactory region, we're targeting to the olfactory region, but yet, there is some amount of exposure to the systemic circulation. It could be either due to leakage of the formulation to the other parts of the mucosa, or it may be even while it is going along the olfactory region. The olfactory bulb and other things has circulatory mechanism, and that might be taking the drug into the systemic circulation. And then brain had significant levels. So this is a good thing that we think we achieved by the way of intranasal administration. Retina, we could not avoid. So there's not as high as here in case of intraperitoneal. By the way, the chronic study, we had the same dose. So in case of intraperitoneal levels, we had in case of intraperitoneal route, we had very high levels of drug in the retina. But in case of intranasal, we had some levels we were not very happy about. We wanted 0 here, but we still saw some amount of drug getting deposited in the chronic study. So all we can say here is we can prolong the duration of administration without letting the significant degeneration of the retinal neurons, without significant loss of vision in the children, by the way of administration of nasal formulation. But we cannot completely get rid of this problem of vigabatrin. Chronic administration. So I mean, like in infants, I think it goes on for 3 months to 6 months to a year. So that's a very long period, and it's hard to overcome this problem of retinal degeneration. We can only postpone the bad things happening when you deliver intranasally. I mean, from the so far data, what we have observed. And then we thought, okay, so maybe if you give intranasally, the vigabatrin formulation intranasally, and to take care of the smaller levels that are accumulated in the retina, so we probably may have to administer something like a protectant. Okay, so we were screening different protectant agents. So when we so before I go into the protectant, let me just look at the show you the taurine and GABA levels. I did not talk about the markers, right? So we only talked about the vigabatrin level. So let's take a look at the taurine and GABA levels. We in the acute study, we did not see a big difference. Of course, in the brain, in the retina, we saw in case of intraperitoneal, we saw a significant increase in the GABA levels, but the taurine levels remain the same. In intranasal, we did not see a significant increase or decrease in this biomarker level in the acute study. But in the chronic study, we saw that the taurine level depleted significantly, GABA level increased significantly in case of intraperitoneal route, but in case of intranasal, the taurine level almost remained the same. There is some trend in decrease, but not as high as what we saw in parenteral administration, but the GABA levels almost remain the same. So there is some potential to overcome the side effects of vigabatrin if you administer intranasally. We are limited by the permeability of the membrane. We are limited by this issue of leakage and getting the drug getting absorbed into the systemic circulation and eventually getting accumulated in the retina. Even smaller levels are dangerous. Okay, so it's not like a concentration dependent effect. Even smaller level of accumulation over a period of time is causing side effects. That's what the literature says. So then we thought, okay, we will not we'll just use this vigabatrin intranasal treatment, but to take care of these levels that we are seeing in the retina over a period of time due to chronic administration, we may have to take the help of some kind of a protectant. Can we overcome the side effects of vigabatrin in the brain? So people have tried different approaches, like taurine depletion has been coined as one of the main reasons for neurodegeneration in the retinal region, and people tried taurine supplementation. Initially in the preclinical model, taurine supplementation was shown to have some positive impact, but in the clinic, it's not really that encouraging, because taurine, you have to administer huge doses to get little into the retina. Vigabatrin has that ability to get accumulated in the in the retinal region significantly, but not all the supplements that we use have the same ability, right? So to get enough into the retinal region, we have to administer a huge amount of taurine, which is practically not possible. So that was one of the approaches people tried, and people tried several antioxidants, and we also tried. We did a lot of studies on looking at what is the potential pathway of vigabatrin absorption into the retina. We looked at the potential ways of blocking that, not greatly successful. And then we screened different protective agents as an adjuvant, that can go with the vigabatrin, so that the harmful effects of vigabatrin on the retina can be mitigated. So we found that the silimarins, basically this is from the milk thistle. This is an extract from milk thistle. There are several ingredients in this mixture, silimarins. We have taxifolin, silicrustin, silidanin, silibin, isosilibin, silidin, isosilidin, several other ingredients as well. There are like 7 or 8 ingredients. One of my students did a lot of work on this ingredients. She developed a derivative HPLC method for quantifying all the silimarins present in the mixture. So we found that so what you say here is the MTT assay, cell viability assay. Most of you are familiar. So the viability, if you look at the cell viability at 0% concentration of a protecting agent, at 0%, there was about 50% of the cell viability lost. So when you don't have protectant, so you see that the cells are significantly dying, but at different concentrations of the protectant agents, these are the different protective agents, that we use, the taxifolin, silcrustin, silidin, silbinin. So we found that particularly taxifolin and silcrustin were at 25 micromolar concentration, was able to mitigate the toxicity significantly. These were the cell line studies. These are not the animal studies. So we need to still perform the preclinical study in rat model and look at the histopathology of the retina after chronic administration of vigabatrin. So we also found that these molecules are effective against the toxicities caused by other anti-epileptic drugs and CNS drugs like gabapentin. We also looked at these are the AFPE cell lines, and then we also looked at its effect on the retinal neuronal cell lines, R28 cells. The previous cell line that I showed you is basically the epithelial cell line, the retinal pigmental epithelial, adult retinal pigmental epithelial cell line. And then here we have the precursor cell line. The R28 is a precursor cell line that is cultured out of the 6th day natal rats. Okay, so these are basically neuronal cell lines, and we found that silibin in this case was quite effective in protecting the toxicity due to vigabatrin. In the previous case, as I mentioned, it was taxifolin in case of silibin in case of vigabatrin, taxifolin and silcrustin in case of gabapentin. So there is a possibility of mitigating the toxic effects of vigabatrin by the way of using protective agents, antioxidants and such things. Intranasal route is definitely a potential route for delivery of drugs into the brain. So I'm concluding now. So there definitely is a potential pathway by which you can deliver the drugs into the CNS. There are several limitations. If you want to deliver huge doses, may not be possible. If you want to deliver particulate matter, somewhere around 100 nanometers, anything less than 100 or close to 100 is called nanoparticles. So you cannot deliver that large particles. There may be possibility of delivering micelles and the liposomes and such things if they're of smaller size. intact, I mean. Okay, so the particles and the vesicles, or the delivery of the particles and vesicles I'm talking about is the delivery of them intact into the olfactory bulb. But there may be other mechanisms associated with larger particles being able to enhance the delivery across the mucosa. And tight junctions, they can be transiently modulated with the use of cationic polymers or any other approaches that may be possible. And then there is a huge you know possibility of delivering neurotropins to the brain to treat the neurodegenerative disorders. And again, as I mentioned, just one approach may not be able to take care of the situation. So you may have to take multiple approaches, like we did in case of neurotropins. We delivered the exogenous neurotropins, as well as we try to enhance the expression of neurotropins in the brain, endogenous neurotropins in the brain as well. Vigabatrin, we are still struggling. We were partially successful, I would say, by the way of delivering through the intranasal route. We kind of able to minimize the exposure to retina, but still we are not at a stage where we can say that you can completely mitigate the exposure, completely mitigate the retinal toxicity by the way of intranasal administration. So this is what we get out of all the studies that we have done so far. So lastly, I would like to acknowledge my group members who worked on this particular project, intranasal route. Shivaram worked on the neurotropins, Prashant worked on ziconotide. So Srinivas helped Shivaram quite a bit. Anita worked on vigabatrin. Srinivas again helped all these people. Srinath Rangappa is the research scientist in my group. Vijay is also a research scientist. Both of them were involved in all the projects that are going on in the lab, and they have great contribution to all the work that we do at the lab, and all the research that is going on in my group is funded by NIH. So when I say National Institutes of Health, it is a bunch of institutes together. It's not one organization. So the NIH, NICHD is the Child Health Department, and then the NIBIB is the Biomedical and Bioengineering Institute, and NINDS is the Neurological Disorders and Stroke Institute. All this partially funded all the projects that I discussed so far, and we have been having a long collaboration with BASF and Ligand, so almost close to a decade now. They have been very kind and generous in supplying all the materials that we need for all the research that goes on in my group. So with this, I think I conclude here. Thank you so much for patient listening. I think I took a little longer time than I should have. So I hope we have time for the questions.
Yes, sir. Thank you, sir. And it was such an informative session and a very deep, experienced way of explaining all the parameters, how we have to do it and how research has to go on. Very informative and very detailed session. I would request all the participants to pour in the questions in the chat box. And kindly, participants, do fill in your feedback form before leaving the meeting. I would now proceed for the question answer interactive session. So we have with us Dr. Vandana Patravake from ICT Mumbai. Ma'am, we are pleasure to have you with us. Ma'am, you can kindly unmute yourself and ask the questions, ma'am.
Thank you, Dr. Murthy, for that wonderful talk. Very, very informative session. And I would compliment Dr. Shobharani. Your student has done a wonderful job.
Thank you.
So it gives us pleasure when our students do much better than we do, and he's
absolutely. Yes, yeah. I'm really feeling proud.
So, Doctor, I had a couple of questions. In fact, a microdialysis as a technique, since we have not used, as the name suggests, will it use only some micro levels, in fact, of the sample? How much sample will it be, you will be analyzing?
Okay, so this is a continuous perfusion technique. So you can be sampling the drug real time, as it gets absorbed and as it gets eliminated, you'll be able to see the real time concentrations. It's a continuous perfusion, like we have this flow through apparatus, right? So we have the diffusion cell, the flow through apparatus, the same way it functions. You can just, it's quite analogous to that. Okay.
Oh.
So you are perfusing microliters. The rate of perfusion, I would say, is like 2 microliters, 1 to 2 microliters per minute is
Right.
the rate of perfusion of the fluid. You would be able to you have to determine the time interval depending on the sensitivity of your analytical technique. If you have a very sensitive analytical technique, you can go shorter time duration, like every 15 minutes, every half an hour. If you have a good analytical technique, always have this problem, right? The analytical method is not as sensitive. So so you can like make it like 1 hour sample. So that would lead to about 120 microliter sample being collected. Then you have to analyze that and get
So typically
calculate, back
yeah.
calculate the
Yeah. So you are
concentration, the
using
extracellular.
LCMS majorly for such experiments?
No, the neurotropins, particularly we did ELISA. So the ELISA kits were obtained from Promega. They're quite sensitive at the picomolar concentrations. But for ziconotide, we had this issue. Probably I should have discussed this. Ziconotide, the HPLC, there's no chromophore. I mean, there is chromophore. It's not very, very sensitive chromophore. We don't have like picogram level or nanogram level sensitivity when we develop the HPLC method. Mass spec is not that specific because it's a peptide, and in the tissue, you might have other peptides of the same size, and that might show up at the same retention time when you do the peptide analysis. So that's why we had to tag it with iodine 125. And then the radioactive ziconotide was used for pharmacokinetic studies. So the levels that I showed may be a little bit of an overestimate. We made sure that all the ziconotide that we sampled by microdialysis was intact. What we looked at was only ziconotide, not just the label, because generally the label comes off from the peptide. That issue is always there. We ran the chromatogram and made sure that most of the drug was intact with the dye. There may be some overestimate for sure.
Thank you for that. There's another question. I was trying to understand your hypothesis for using carnosic acid when you use it in combination with chitosan. So just because it's meaning antioxidant, or was there any other hypothesis you had in mind when you tried these in combination?
Not really. So we, as I mentioned, this is not our discovery. So there was a paper published using the cell lines. They have screened different agents that can enhance the neurotropin levels in the neuronal cell lines, and they came out with this lead molecule, carnosic acid, was found to be really working very well. So we were anyway working on intranasal road. So we thought, okay, why not try out this and see if this really works in vivo? So we kind of borrowed that idea from the published literature. We don't have any hypothesis, or we don't know the mechanism and such things. So we know that it is an ROS and probably maybe helping the well-being of the neurons. It is an antioxidant working against ROS. That much only we know superficially. We don't know the
thought I was also trying to relate, but only that hypothesis comes in mind. And
right.
For the last study, also any mechanistic part done to know why is it that it goes so much to retina and gets lodged there?
It's not known. So far, people have been struggling. We struggled a bit to find out, what are the potential pathways of absorption of vigabatrin into the retina because of its structural similarity to taurine. We found that the vigabatrin is competitively getting absorbed through the tau-T transporters. Tau-T transporters are responsible for taurine absorption. So this is, replacing taurine and getting absorbed into the retina through the stealing the tau-T transporters. So that's what is the major mechanism that we found. But we saw in our studies that besides the tau-T transporters, there is some other transport mechanism associated. Also, there is some passive absorption also into the retina. So it is not just one route. If it was just one route, we could have probably blocked that and prevented the entire exposure. That did not happen, unfortunately.
The final question is chitosan now approved for use? specifically, I mean, US FDA had certain issues with it?
Yeah, I think certain grades are there in the GRAS list. So there was a lot of debate going on the potential use. And then some of the products containing the chitosan were approved as a part of the NDA applications. So that's how most of the excipients gets approved in the FDA level, right? So they wouldn't get the excipient itself approved by FDA. They would just go with the dosage form and get it approved, show the
Absolutely.
safety, show the efficacy, and a backdrop, you got your excipient approved also.
Thank you. Thank you so much, Dr. Murthy, for answering all my queries and for that wonderful lecture. We
Thank you,
hope we
Dr.
can
Vanda.
hear you often.
I'm following you on your all the lectures that you're giving.
Oh.
I was at a couple of lectures, that you gave to some of the colleges in Mumbai.
Thank you so much.
Yeah.
Thank you, ma'am. Sir, we have a next question from Dr. Vedamurthy Joshi. Sir is telling there is a practice of delivering ghee or oil-based herbal doses through nasal route. How effective is that? Sir wants to know your opinion about it.
Could you repeat the question again, please?
Yeah. There is a practice of delivering ghee or oil-based herbal doses through nasal route. How effective is that?
I can only speak for delivery of pure compounds, be it small molecular peptides. I'm not sure if herbal compounds can be, herbal products can be directly delivered intranasally. As you know, there may be some practice in Ayurveda, like in case of Nasya, but I don't have any experience delivering the herbal extracts as such. We delivered carnosic acid, which is a silymarin, which are all herbal components, but they're all pure components.
Sir has another question. The next question, definitely from Sir again. And have you come across any work where the drug is delivered using these bases? Have you come across any work where the drug is delivered using these bases?
The question is not clear, madam. These bases means?
The bases, that oil, the ghee, all these bases actually.
Not really. I have not seen any reports with the use of course, lipidic ingredients. Let's put it in the pharmaceutic perspective, right? So lipidic ingredients are there, like people have been using different fatty alcohols and different fatty acid esters, different types of lipid excipients for manufacturing nanoparticles and solid lipid nanoparticles and different nanotechnology based products, but not really as such the crude oil. Don't know why one would do that.
So the next question, it is from Professor Dr. Gyanachandran. He wants to know your comment and opinion about snuff powder used by nasal route in olden days as a CNS stimulant.
So what would be my comment? Is that the question?
Yes, sir. Your comment and opinion.
Don't have any comments on that, madam. I've only seen people snuffing the powder, but no experience or did not get into the pharmacology of it.
So we have another question from Mr. Sudhartha Dhaka. He has two questions. The first one is any type of toxicity observed in intranasal and brain targeting? Is there any type of toxicity which is observed in intranasal and brain targeting?
Well, this road, I think I take it this way. Looks like he's asking if there is a pathway existing for the molecules to go from the olfactory region to the brain. Is there a possibility of all the pollutants and such things, the toxic agents getting into the brain via this road? Yes, there is a possibility. People are looking into the environmental toxicants and their impact on the brain. So when you inhale this environmental toxicants, there is a potential for those molecules to get accumulated in the brain and have some kind of a negative impact. So that kind of research is going on a lot in the CDC area, the disease control area, and then in the environmental science area.
So the next question from him is again, how does the optimization of the dose being taken place? Is QBD or DOE being applied in formulating this type of delivery?
Yeah, you can use QBD or DOE. So we did use those approaches for making nanoparticulate drug delivery systems and such things when we initially tried delivering these molecules using the nanotech products via intranasal route, and then we kind of terribly failed. We optimized the dosage form, the release was great, stability was great, and everything was fine. But when we administered it intranasally in the animal models, we were not able to get a lot of drug into the brain. So there was I would say there was some approach, there was some studies carried out on those areas of DOE and such things for developing the formulations. But it may not be required for very simple formulations like solutions and the in situ gels and such things. You can probably you have like 2 or 3 formulation variables, and you can play with them and optimize the formulation. You don't really need a factorial design or other kind of complicated designs to formulate such formulations. When you make complicated dosage forms, yes, complex dosage forms, yes, you may need such approaches. So we took a straightforward approach most of the times. We just depend more on the in vitro and in vivo results for us to guide on how we have to tweak the formulation, rather than do a lot of mathematics before even we try anything. We evaluate formulation for performance.
The next question is from Sharwari Hardikar. Sir, it is how to decide the dose for intranasal administration.
Yeah, this question is like an ever-longing question in case of topical dosage forms, in case of skin products, intranasal products, mucosal products, and everything. See, I say that you should have some idea about what is the minimum effective concentration of drug in the target site. You should know how much of the drug is bound, because only the free drug is going to be effective. And the microdialysis technique, other advantage with microdialysis technique is that you are sampling only the free drug, not the bound drug, because of the dialysis membrane. So you will know the actual effective concentration of drug in the extracellular fluid when you do the microdialysis. When you do decapitation of the brain and extract from the brain, you probably may overestimate the active concentration of drug, because you are accumulating both the unbound and the bound form of the drug. So to answer her question, so these are the things that you need to do: MEC and the extent of delivery, or the permeability of the drug across the membrane, and the extent of binding. All these factors need to be considered. You have to run some trial error experiments in the lab to know, you're at least if not more than effective levels, at least near therapeutic levels, in terms of delivery, so that you have some scope for enhancement and such things to achieve the therapeutically required amount of drug in the target tissue. So there is nothing like a formula that we can use to calculate the dose for topical dosage forms, as far as I know.
Thank you, sir. So one more question: how the rat and mouse related data is extrapolated to the clinical conditions, and particularly if the intranasal formulation is tested in the rats and the data is to be related to the humans?
There are certain models, PBPK models and such things available. We did some kind of a mathematics. It is still in the mathematics level. We don't know how things translate from animal model to human subjects. As I mentioned, there are some anatomical differences and physiological differences, biochemical differences between the rodent model and the human subjects. There is a difference in the ratio of olfactory surface area to the other regions of the mucosa between the humans and rodents. The number of enzymes present in the olfactory regions are different. The types of enzymes present in the olfactory region between the rodent and the human is different. There are several things. So all these studies that we did are only like proof of concept, exploring the pathway. This is not something like you do in case of a small molecule, where there is a possibility of extrapolating the drug levels from the rodent to a human subject. I don't have any such formula, particularly for the biological molecules. So there's nothing of that sort available. The PPPK models are often fallen back on or relied on to get some kind of an idea, but it's not a sure go.
Okay, so the last question, I think it is from Dr. S. Rajarajan. Is there any specific reason for only using rat, as rats are used for the nasal animal study? Can you explain, sir?
So yeah, the reason why we use rat is like, they're easy to deal with, and that's what we are approved for. That's the main thing. We're not approved for larger animal use. I would love to use something like mini pigs. If it is possible. They're pretty expensive. Particularly here in the United States, to do animal studies is pretty expensive. So I would, anything, a new concept that we are trying, or anything that we are exploring, we would first do it with the smaller animal model. And if we have any positive results, then we can take the risk of investing on larger animals. So there is nothing like a specific reason why we chose rat. It is just the convenience.
So one last question. Will irritation of the epithelium improve the drug availability?
I don't think irritation would improve the bioavailability. It would rather lead to secretions and drainage of your drug from the applied region in case of intranasal tract. It is not like skin. I think I mentioned it when I was explaining about the barrier. So the terpenes and different agents, they irritate the skin. They cause some kind of a change in the lipid arrangement in the skin, and improve the permeability, because the passive permeation is a predominant mechanism in case of dermal absorption. But in this case, there's limited scope, for use of chemical permeation enhancers that would modulate the lipid structures and such things. So I think otherwise, I think use of any irritating agents would rather hamper the ability to deliver drugs effectively into the brain.
Thank you, sir. And thank you, sir, for patiently answering all our participants' queries. Now, I would like to summarize the session. Sir started with the anatomy of nasal tract and how it connects to the brain via the olfactory route. He gave the example of a research paper of smelling rose scent during the sleep time and how it shows a stimulus to brain, which enhances the memory. Sir talked about ancient Indian medicines, about Charaka Samhita, and how it explained the path of nose to brain. He gave examples of efficacy of Nyasa, that is the national nasal medication in coma, which was just a case study with what Sir discussed. He told us how microorganisms know the olfactory route very well and reach the brain through the nose via several examples, like brain-eating amoeba. Then he started discussing how we can deliver drugs through the nasal to the brain, and he clearly explained the anatomy of the olfactory region and how it will reach the brain. He talked about limitations of the route, how and why permeation enhancers are called brain modulating agent, the tight junctions and the biological barriers, and how they can be used for the delivery of macromolecules, and for that, how to open and exploit, and how the tight junctions can be opened and exploited for the delivery of drugs. Then the study of tight junctions in the olfactory mucosa, the neurotrophic factors, two types, the growth factor, the nerve growth factor, that is the NGF, and the brain-derived neurotrophic factor, that is the BDNF. Even for the treatment of depression of the macromolecules, BDNF were delivered through the olfactory route. Sir did the microdialysis, which is not very common. And then he also explained each minute details regarding the microdialysis and how you will get the inferences from that. Sir told about the multiple approaches to treat the neurodegenerative diseases. The carnosic acid is known to enhance the BDNF and the NGF, which was administered as an intranasal in 5 different groups of the animals with different composition and its effect and how they had calculated all the details. Sir had also performed pharmacodynamic studies by using forced swim tests in rats, subjected them to immobilization, stress, treated with neuropathogenic conditions. He explained the histopathology of the olfactory mucosa and the innate gyrus of hippocampus. He explained another application with the peptide, that is ziconotide, and it is used for a chronic pain management through the interthecal route, and how he used the nose to CFS delivery for the ziconotide. Now, this project was funded by the NIH, as sir also explained. He also explained about the vigabatrin and how it is used for the refractive epilepsy in infants, and the racemic mixtures is used, but sir has used only the S factor and how it has prevented the retinal damage. All that sir has explained very clearly to us and in a very deep manner. He had concluded that we can use this part, but huge doses cannot be given. What are the applications? What are the advantages and the disadvantages of the route? Thank you, sir. I don't think I've explained so well as you have done, but it was very great opportunity for us to be with you and hear you. Thank you. Now I would like to propose the vote of thanks on this memorable occasion. I would like to thank and express my deepest gratitude to the speaker of today, Dr. S. Narasimhamurthy sir, for helping us understand the myths and the truth of nose to brain delivery. Thank you, sir. My heartfelt thanks to the management of Alamein Education Society to provide us with all facilities to conduct this international webinar. I would like to convey my special gratitude to our respected principal ma'am, Dr. Shobha Rani Hiramat, Dean, Pharmacy, RGHS, for providing us with constant support and ideas on making this international webinar a great success. Without her guidance, we would not be able to achieve such heights of success. Thank you, ma'am. I would like to extend my thanks to the organizers, Dr. Preeti Karwa and Mr. Rakesh Panda, who worked relentlessly at the backdrop and took care of each and every minute details for the perfect conduct of this international webinar. But the biggest thanks goes to all the participants who had taken their time out and have been here with us for this webinar. Thank you, one and all. We have come to this webinar series, and participants, kindly fill your feedback form before leaving. You will be receiving your certificates within 4 to 5 working days. We will be back soon with another new international webinar on the 15th of September. The notification and the invitation for the same will be rolled out soon. So this is Tanushri taking your leave. Bye from all of us at Alamein. Bye, sir. Bye, ma'am. Bye, all of y'all. Thank you.
Thank you, Murthy, once again for sparing your valuable time. Thank you.
Thanks for the opportunity. Thank you so much.